Hello everybody, welcome to the channel. Before we begin, give this video a like, subscribe, and share this video if you found it helpful. Alright, let's get into the question. Gastroenterology and pathology. A 72-year-old male with a history of hypertension, coronary artery disease, and chronic atrial fibrillation presents to the emergency department with a 4-hour history of sudden onset, crampy abdominal pain, and 2 episodes of diarrhea with blood. He describes the pain as being localized to the left lower quadrant. On physical examination, his temperature is 99 degrees Fahrenheit, his heart rate is 92 beats per minute, and the blood pressure is 135/85. Abdominal examination reveals mild tenderness to palpation in the left lower quadrant without guarding or rebound. Laboratory studies show a mild leukocytosis and a normal serum lactate level. A CT scan of the abdomen with intravenous contrast shows focal thickening of the colonic wall at the splenic flexure. Which of the following is the most likely underlying mechanism of this patient's condition? Option A, embolic occlusion of the superior mesenteric artery. B, transmural inflammation with non-caseating granulomas. C, transient hyperperfusion of watershed areas of the bowel. D, outpouching of the mucosa through the muscularis propria. I'll give you a few moments to answer. Alright, if you chose option C, you'd be correct. Now, let's go into a brief explanation as to why the other answer choices are wrong. Option A, embolic occlusion of the superior mesenteric artery. That would be acute mesenteric ischemia. Now, this typically presents with pain out of proportion to examination findings, an increased lactate level, and the CT would usually show involvement of the small bowel. That can't be it. Option B, transmural inflammation with non-caseating granulomas. This is typically seen in Crohn's disease. Crohn's disease typically presents in younger individuals and also has a chronic relapsing history. You would see in the vignette, the patient might mention that, I had diarrhea with blood a year back, as well as crampy colicky abdominal pain, but it went away, and it came back, it went away, so it waxes and wanes, right? And additionally, more importantly, the vascular history of this patient points to another etiology. And finally, D, diverticulosis or diverticulitis might present similarly to this patient, because diverticulosis and diverticulitis typically presents in elderly patients and also has left lower quadrant abdominal pain. But diverticulosis typically has painless diarrhea with bleeding. But more importantly, the CT scan does not show involvement of the sigmoid colon. It does not mention if diverticula are present, and there is no mention of pericolic fat stranding, which you would see in diverticulitis with inflammation. So let's go into a little explanation of why option C is correct. Now over here we have a little diagram of the colon. Over here we have the cecum, the ascending colon, the transverse colon, the descending colon, and the sigmoid colon. And over here we have the rectum. Now, the superior mesenteric artery supplies the cecum, the ascending colon, and 2/3 of the transverse colon. Now, the inferior mesenteric artery supplies one third of the transverse colon, the descending colon, as well as the sigmoid colon, and the upper portion of the rectum via the superior rectal artery. So what are watershed areas? Watershed areas are basically areas that sit on the border of two arteries and so get the least reliable blood flow. Now, over here at the splenic flexure, because the spleen is typically present over here, right? This sits at the border of the superior mesenteric artery and inferior mesenteric artery. And so this area of the colon receives the least reliable blood flow. And so if you look at the vascular history of this patient, this patient probably has atherosclerosis of his major arteries, including the inferior mesenteric artery and inferior mesenteric artery. And so this causes hyperperfusion of the splenic flexure, and because there's hyperperfusion, there's decreased blood flow and increased ischemia of that site. This causes an increase in mucosal injury to that area, and that would cause bleeding into the lumen, which would then cause the diarrhea with blood, as well as colicky abdominal pain due to the ischemic damage that's occurring. Now, I would just like to point out that some of you might be wondering why I've included this this drawing of a character. Well, this character, if some of you know, is known as Griffith. And Griffith is a character in Berserk who is basically evil, right? So you can imagine that this point over here, also known as Griffith's point, can cause, or rather is subject to ischemic colitis. So if you see a history or a similar vignette like this one, just think to yourself that this patient might have ischemic colitis at Griffith's point, and this little picture will remind you. All right, hope that helps. Thank you.